Namaskar, Zohar, and good evening to one and all. Myself, Dr. Suman Sinha, Chairperson, Vaginal Surgeries Committee, FOGSI, and your host for today's podcast. It gives me immense pleasure to welcome our dear FOGSians, revered dignitaries, and our esteemed viewers in the 301 episode of Gyan Pravah, a name that beautifully expresses our mission of continuous flow of knowledge, a celebration of shared knowledge and wisdom through thought-provoking conversation and Foxy's unwavering dedication to academic excellence across borders, specifically empowering mind and enriching women's health through our motto, एक राष्ट्र एक मिशन स्वस्थ नारी समृद्ध वतन हर हर घर फॉक्सिया. It is also an incredible opportunity to welcome two iconic leaders, Dr. Sunita Tandulwadkar, President FOGSI, and Professor Vivekanand Jha, Executive Director, George Center for Global Health India, and Chairman of Global Kidney Health at Imperial College London. Former Professor Nephrology and HOD of the Department of Translational Regenerative Medicine at PGI Chandigarh. I'm truly blessed to share screen with both of them. The theme of our today's podcast is how well your kidneys are working, looking at the rising incidence of kidney disease globally. And now, as a protocol, I'll be very, very brief to introduce our FOGSI president.
Suman, please don't introduce me. I'm
Madam,
so glad.
One line. Okay, then. Well, then, can I?
Okay.
Just very, very brief, just for my guest faculty. Dr. Sunita Tandulwadkar is a committed leader with charismatic challenges. This Gyan Pravah Podcast Series is a prestigious initiative solely conceptualized and executed by the visionary leader and unstoppable force in women's health. She leads 48,000 strong federation with unparalleled purpose and compassion. She is globally acclaimed IVF specialist and endoscopic surgeon who has transformed the impact of infertility care in India. She is Director Solo IVF Clinic Pune, Director Alive Regenerating Wellness Center Mumbai and Pune as well, Chief of IVF and Endoscopic Center Ruby Hall Clinic Pune. And so
thank
Madam,
you, Suman. Thank you for your love. Thank you for your kind words.
I really welcome dear Madam in the 301 episode of podcast series. And now I formally request our President FOGSI to welcome our guest faculty, Professor Dr. Vivekanand Jha, Chairman Global Kidney Health. Madam,
thank you, sir.
And welcome.
Thank you. Thank you, Suman. Thank you for your kind words. And Dr. Jha, it is such a great honor that you have come for our FOGSI platform. I joined only for a few seconds just to welcome my faculty who have taken out time and they are on a FOGSI platform. It's our honor, sir. And this podcast is designed only for this 30 committee chairperson. Every day at 8 p.m., one of the dedicated chairperson, they come and they have a fantastic dialogue with all our faculty from academic, non-academic field, from India, globally. So it's so much learning experience. And I think every day 8 p.m. joining and doing this committee chairperson have done a tremendous job. I'll be joining the viewers link to listen to both of you. She shared me your all CV and it's great what one Indian in the field of nephrology. I know it is a loss for India, but you are taking globally through your global health. Fantastic, sir. I just want to ask one thing. Is a regenerative medicine or a stem cells for a kidney diseases is there in London or it is not yet entered?
So first of all, thank you to both of you for the kind words and the warm welcome. Just specific response to your question, stem cell therapy is very much in the realm of research right now. So I don't think that there any stem cell or regenerative therapy is being in use for kidney disease or other type of chronic diseases at this time. The condition in which these therapies are most widely used are hematological conditions and a few very, very specific monogenetic disorders.
Okay. Thank you. I just wanted to know what is UK doing. Thank you so much, sir. Lovely meeting you, and I'll join the viewers link. Thank you.
All right. Thank you.
So now I take the opportunity to welcome and introduce to the gathering our guest faculty, Dr. Vivekanand Jha. He has a dual CV. As I have earlier said, he is the Executive Director, George Center for Health India, and Chair of Global Kidney Health at Imperial College London. He has served as professor at the Oxford University and PGI Chandigarh. At PGI, he was Professor of Nephrology and HOD of Translational Regenerative Medicine. He is a graduate of Patna Medical College and postgraduate in Medicine and Nephrology from PGI Chandigarh and Basic Sciences Research Fellowship from Harvard University and Birth Israel Deaconess Medical Center, Boston. He has had leadership roles in many national and international organizations. He was president of International Society of Nephrology between 2019 to 2021. He has been executive committee member of the International Society of Nephrology from 2013 to 2019. He is president-elect of Asian Pacific Society of Nephrology and Secretary General of Indian Society of Nephrology. He has been on the editorial board of several journals as an editor of the Cochrane Kidney and Transplant Group and as a section editor of the Oxford Textbook of Nephrology. He is a member of WHO Task Force on Transplantation of Human Organs and Tissues. He has over 600 publications and has authored and chaptered 50 books. He leads a national consortium of nephrologists involved in multiple cohort studies and clinical trials to find affordable solutions to neglected problems. Welcome Dr. Vivekanand Jha once again, and now we will take up the questions.
Thank you.
So to begin with, what are the early warning symptoms of a kidney disease? How will you know yourself? Suppose being a layman, how can I detect myself of being suffering from kidney disease, or I have some problem with the kidney health?
And that's a very good question. Early stage kidney disease is often silent, in fact. And so there are very few symptoms that appear. But when they appear, actually, they indicate more advanced disease. It is because of the fact that the kidneys have great adaptive capability. When initial damage appears, the kidney physiology adapts itself in such a way that it doesn't lead to any change in body homeostasis, and the person doesn't feel any symptoms. When the symptoms appear, they usually indicate loss of almost 50% of kidney tissue. And those symptoms are fatigue, poor appetite. Sometimes people have muscle cramps, they have difficulty in sleeping. If it advances even further, people develop swollen feet, they become short of breath, they might start having dry, itchy skin. Urine becomes foamy in certain situations when kidneys start leaking protein, and people will have increased urination at night. It's important to mention here that there is some degree of increase in urinary frequency at night as one ages, but that really becomes very, very high in those who have kidney disease. So essentially what it means is that if you want to detect early stage kidney disease, it can be done only through tests.
Yes, only. So what are those tests to check your kidney health? Can you briefly tell us?
There are two essential tests. One is serum creatinine, and that serum creatinine test is used to estimate glomerular filtration rate. The glomerular filtration rate is the filtration ability of our kidneys, how well are they filtering blood of its toxic substances. The other test is the ability of kidney to retain proteins in the blood. Our kidneys, because blood is filtered through the kidneys act as a barrier and prevent leakage of protein in the urine. But when that barrier becomes abnormal, protein starts leaking. And so we look for the presence of protein in the blood by doing several kind of tests, which could be dipstick test for protein, but the more sensitive test is what we call urine albumin creatinine ratio test. The normal eGFR value is more than 90 mils per minute, and the urine albumin creatinine ratio is less than 30. If the GFR goes below 90 and if the urine albumin creatinine ratio increases above 30, it indicates kidney damage. And once we see any abnormality in these, then additional tests may be needed, and they may include, detailed urine microscopic examination, ultrasound of the kidneys, and so on.
So if we do just a microscopic examination of urine, we can very well see the amount of albumin will be more there, and we can be very, we can have a warning sign that we go ahead with the further tests.
So urine microscopy doesn't tell you about albumin. That is something you can do by dipstick testing.
Specifically dipstick test.
Microscopy tells you the presence of cells. For example, red blood cells, white blood cells, casts, or presence of crystals, etc.
So, but how will we know? So then I wanted to know that we write only to our patients, like we get patients in pregnancy, then we just write microscopic examination of urine. But there I will have to mention especially albumin and sugar.
Yeah. Albumin creatinine ratio should be done. Urine microscopy is helpful to identify if someone has UTI in pregnancy.
That is for the, just to rule out the renal disease in those patients, I wanted to be very specific.
Urine albumin must be looked for because that is an early sign of development of preeclampsia as well.
Yes. Thank you. So, can family history of blood pressure and diabetes be a risk factor developing renal disease in their offspring?
Yeah, that's true. People who have a first-degree relative with kidney disease, especially, so not only diabetes and hypertension, but a family history of kidney disease also. So if someone has another family member who has kidney disease, then the risk is increased by almost threefolds. But the presence of diabetes and hypertension, especially if it is associated with kidney disease, further increases the risk of development of kidney disease. So that's something we should always be mindful of. If someone has another family member who has one of these conditions, they should consider themselves a slightly increased risk.
So another question is how to keep your kidneys healthy?
Right. There is no magic trick to keep one's kidneys healthy. Kidney disease typically is more likely to develop who have already pre-existing risk factors, and these risk factors include diabetes, hypertension, those who are obese, those, as I said, who have family history of kidney disease, those who have cardiovascular disease, etc. So it's really important that they should pay extra attention on kidney health. And this can be done by controlling blood pressure, keeping it below 120/80 in those who have hypertension, and also managing blood sugar appropriately. Now there are very good medicines which can control blood sugar. All of us should do regular exercise. We should eat a balanced diet. We should limit salt content of our diet. We should also limit added sugars. If someone is smoking, they should stop smoking. And if someone has high cholesterol, they should also manage their cholesterol. There are many people who take painkillers indiscriminately, and non-steroidal anti-inflammatory agents can increase the development of kidney disease. So that should be, it's not that one should never take it, but its use should be limited. For people who go out and work in hot and humid environments, it's important that they stay hydrated. So these are the various measures that one can take to keep one's kidneys healthy.
So viewers, I had the direct question from our guest faculty and has given the answers. So do take good care of your kidney health. And whatever has been told, that is not very, very difficult for any one of us. So we should follow. We should be exercising every day. Take adequate amount of water in any form you want, you can take, and keep a control on your diabetes, blood sugar, as well as on your blood pressure.
Correct.
So is there So main causes we have dealt. So can we reverse the kidney disease? Suppose we are diagnosed with a kidney disease, can it be reversed
So there are two
without
types
taking
of
medicine?
Yeah, there are two types of kidney disease. One is called acute kidney injury, which develops suddenly, and it is due to a reversible factor. It can develop due to infection, it can develop due to hypotension, blood loss. These are the common causes. So once these causes are treated, then acute kidney injury can be reversed. But unfortunately, chronic kidney disease will not get reversed. However, uh, even though the previous kidney damage that has happened is permanent, progression of kidney disease can be substantially slowed down or even halted completely so that it doesn't progress any further. There are new agents which include ACE inhibitors, angiotensin receptor blockers like Ramipril, Telmisartan, etc. They have been present with us for a long time, but there are some newer drugs which are SGLT2 inhibitors, GLP-1 agonists. They were primarily developed for treatment of diabetes, but they have very, very good kidney protective properties. So they can slow progression, and sometimes they can also improve kidney function. But we shouldn't forget the basics, which is early detection and aggressive management of blood pressure and blood sugar, etc., because that also will slow down or halt progression, which will prevent, dialysis in many, many patients. And dialysis is not a pleasant therapy.
Agreed. So can stress impact kidney function?
Yeah, stress doesn't impact kidney function directly, but psychological stress correlates with higher kidney disease burden or markers. For example, people who are on dialysis, they have a very high proportion of presence of anxiety, depression, and they also complain of stress. Chronic stress can also dysregulate stress hormones. It can cause inflammation, which can cause a vicious cycle where kidney disease can worsen. So kidney disease can worsen stress, and then stress can also worsen kidney disease to some extent.
This is the part of the question which I had asked you earlier. How often we should get our kidney function tested? You're not,
Right.
yeah.
So it
For a normal person.
Okay. A normal person, an adult, should get above the age of 18, let's say once in 3-4 years. Above the age of 50, once a year is recommended. But those who have diabetes or hypertension also should get tested once a year, no matter what age they have. For those who are diagnosed with chronic kidney disease, they should actually consult their nephrologist or their physician to determine the frequency of testing, because it may need to be done more frequently, like once every 3 months or once every 6 months, depending on the severity of the disease. But for healthy individuals, between 1 and 3 years is the appropriate testing interval.
That will be urine for albumin, creatinine, and GFR.
Correct. If it is normal, then you need not test it very frequently. Once every 2 to 3 years is fine.
Thank you so much. This was very important. So what are the first warning sign of kidney failure?
So as I said in response to your very first question, once the kidney failure sets in, people start developing fatigue, reduced energy, they become weak and feel breathless, because this happens from toxic buildup. People with kidney disease will also develop anemia. So in fact, if someone has unexplained anemia, kidney function should be tested in those individuals. They will start having increased urinary frequency. Then depending on the disease, urinary urgency, burning, etc. may also develop. And when the kidney function becomes even worse, then appetite goes down, people start developing nausea, they may have difficulty in even concentrating, muscle cramps appear. So these are the common signs, and if it is still not addressed properly, people can start to lose consciousness, they can have seizures, they can become breathless and start vomiting.
It's a very serious situation then. So
Yeah,
this it is almost like end stage kidney disease.
correct.
And is it ये पक्का है कि it will lead to death or it can be recovered from the end stage kidney disease?
Well, if left untreated, then
Then,
end-stage kidney disease will certainly lead to demise of an individual.
but a stage in time can heal.
Yeah, people can live, quite a long and productive life with dialysis or kidney transplantation. Kidney transplantation is the best treatment, and dialysis is next best. For transplantation, obviously, one needs a kidney donor. The kidney donor typically is either a family member, or kidneys can also be retrieved from what we call deceased donors, or in the past they used to be all called cadaver transplants. So which means individuals who have unfortunately sustained maybe brain injury and they're irreversibly damaged. The brain is irreversibly damaged, but other organs are still functioning. Their organs can be used for transplantation in other individuals. So that is the way to survive. So in fact, kidney is one of the organs when even if it fails, there is still many ways of ensuring longer term survival of those individuals by dialysis or transplantation.
Do you prefer transplant over
Yeah.
dialysis?
In suitable subjects and those who have a kidney donor, transplantation is always highly preferable.
That gives better age of life.
It increases the longevity substantially. It also gives a much better quality of life. It ensures freedom from dialysis, because if someone is on dialysis, they either need to go to a dialysis center 2 to 3 times every week, or they will need to do peritoneal dialysis, which can be done at home, but they do get tied down to the process of dialysis.
Yeah, it's a very lengthy process. So I think we have dealt with the complications of kidney failure. Whatever you said, it was the complication.
Yeah. So in terms of complications, I'd like to add a couple of things. I already mentioned anemia, right? So people become anemic, and this is because kidneys normally produce a hormone called erythropoietin, which is responsible for production of red blood cells in the bone marrow. Kidneys also have a couple of other endocrine functions. They regulate bone and mineral metabolism. So once the bone and mineral metabolism becomes abnormal, then bones can become weak. And if again not managed properly, fractures can appear. Bone and mineral metabolism also can lead to hardening of blood vessels or arteries, which increases the risk of development of kidney disease. Hyperkalemia can develop, which can lead to ventricular tachycardia, ventricular fibrillation, etc. And then there are other electrolyte abnormalities like metabolic acidosis. There is fluid retention. Kidney disease also increases the risk of development of infection. And finally, malnutrition is a very important problem which should not be neglected in people with kidney disease.
Yes. Nicely taken up the question, Dr. Bivika. Now, how much water? This is a very, commonly asked question, so I wanted to put up here. How much water one should drink to prevent kidney disease and kidney stone as well? Can kidney stone be a risk factor in causing kidney disease? This is a very, very common question. Every patient, even if they are not suffering from kidney disease, they'll ask, कितना पानी पीना चाहिए और उसको पीने से मैं बच जाऊंगी इस बीमारी से. So I wanted to put up this question here, and your answer, please.
You're right. This is a very common question, and people often have this feeling that if they just drink enough water, they will not develop kidney disease. But like I said, there are many other risk factors for kidney disease, and just drinking adequate water doesn't prevent if one doesn't take care of those other risk factors like diabetes, hypertension, obesity, etc. But coming back to your question, as a rule of thumb, between 2 to 3 liters of water intake every day is sufficient for an otherwise healthy individual. But that will increase, for example, with temperature. Like if someone is spending a lot of time outdoors in hot climate during humidity, then of course they need to drink more. I think one way to tell whether we are drinking enough water or not is simply by looking at the urine color, our own urine color. If the urine is clear or just light yellow, then that means we are drinking sufficient water. If it becomes dark yellow, then obviously there is, or one starts getting a little bit burning sensation while passing urine, that means that they need to drink more water. One can, to prevent stone, one can add citrus juice, orange juice, etc., because citrate binds calcium and blocks stone formation. And you also asked the question, can stones cause kidney damage? Yes, stones can cause kidney damage. But again, if the stones are small, then they don't normally cause kidney failure. But if there are multiple stones, if they get big, or if they block the passage of urinary flow, then of course they can cause kidney disease if not managed in time.
So one can live with kidney stone, which that is very, very small and it is
Yeah.
embedded in the lower pool, they can stay. They can,
Yeah, they can stay, but there is always a risk if the stone moves, then it will cause renal colic, which is one of the most severe types of pain, maybe comparable only to labor pain, which women of course know.
Nowadays, lithotripsy and these things are very non-invasive.
Yeah, there are very good ways of taking care of stone now. So people should consult their doctor and make sure that they are appropriately managed.
Thank you. So there is one more question, and we sometimes get these type of patients on measuring blood pressure. And we have taught our nurses to measure blood pressure in both the arms, and they come running to us. Madam, in this, there is a difference in the reading of blood pressure in both the arms. So, is there any significance of any renal disease if the difference is much, much higher?
Yeah.
If it is within 5 to 10 millimeters of Hg, then it's okay. But suppose the discrepancy is more than 30 millimeters or something like that. Should we be worried and refer the cases to a nephrologist?
Yeah, good question. So the first thing I would like to say is that now there are recommended methods for measuring blood pressure. It's great that you're asking your nurses to measure blood pressure, but ideally now they should use oscillometric devices which are available, and they should be validated, and they should be
Our instruments are validated, sir.
Yeah. So that's good. Yeah, that's good. It's not for you, but there are so many of us. Even many nephrologists are not using validated instruments, if you'd like to know. But coming back to your specific question, yes, up to 10 millimeters of mercury difference in blood pressure between the two arms is not a matter of concern. But if it is more than 10 millimeters, it indicates two things. It might indicate the presence of undetected vascular disease, which causes difference in blood pressure. And secondly, it also indicates increased cardiovascular disease risk. Each 1 millimeter difference will increase the predicted risk of angina, heart attack, stroke, etc. And if the difference is 15 millimeters or more, then most likely you said 30 millimeters. 30 millimeters certainly is a matter of concern, and this might indicate that maybe one of the subclavian arteries is narrowed. This can happen typically in aortoarteritis or Takayasu's arteritis. So one should definitely not neglect this, and people with so much difference should undergo further evaluation.
Yeah. So just a minute, there is problem with light. I'll go for the next question. You can hear me now?
Yeah, I can hear you very well.
Your opinion on protein intake, limited or they should take limited protein or unlimited protein intake, because these days everybody is suggesting protein khao, take eggs, 2 eggs every day or 1 egg every day. So what is your suggestion on this, preventing kidney disease? I mean, on that aspect. Should we, what about the vegetarians? How they will?
Yeah. Look, as it is, you raise an important point. As it is, we Indians, even those who eat meat, they are mostly vegetarian, right? They don't eat meat every day. They will eat meat maybe once a week or something like that, right? So, and we have done studies which show that the protein intake in Indian population is relatively low. So there is no reason to restrict protein intake, either animal protein or plant protein. But those who already have kidney disease, they should restrict their animal protein intake. Restrict doesn't mean that they should never take it, but they should, as it is, they're taking once a week, so that's fine. They don't need to, they need to change anything.
Plus,
But
who is not
plant
suffering,
protein,
yeah,
sorry,
not who is not suffering from kidney disease.
who's not suffering, yeah, and even those who are suffering from kidney disease, what we recommend is intake of about zero point 0.8 grams of protein per kg, and preferably plant proteins, because plant proteins are better for kidney health. They contain less sodium, they contain less saturated fat, they also have reduced metabolic load. But again, let me re-emphasize that please don't eliminate animal protein entirely. Because we need to plant proteins, the bioavailability of plant proteins is relatively low. So some degree of animal protein intake is still recommended in people, even those who have kidney disease.
So, can we take daily milk and curd and all?
Yes,
Because
yes. One can take
some
milk or curd.
thoughts, some thoughts wherever I have studied somewhere that it is the milk, you shouldn't take that much milk. I don't know why, but it was written somewhere, so I wanted to ask
Yeah.
about it.
So it's a common perception that once someone has kidney disease, they should not take protein from any source. But like I said, as it is, the protein intake in Indians is very, very low.
Very low.
If we limit protein intake further, it almost disappears from diet. And we all know that protein is essential for everybody, including those with kidney disease.
For the
Uh,
muscle health, you need protein.
yeah, exactly. If they stop taking protein, they become frail, their muscles become very, very weak. So that is not good for long-term health outcomes.
So, another question. Do tea or green tea caffeine helps in maintaining kidney health? Nowadays, fashion, and I'm taking green tea, black coffee, because one of my friend was supposed to visit me today, and he said, "Be prepared with black coffee."
Yeah.
So, does milk coffee and black coffee has some difference in
Yeah.
maintaining kidney health?
Well, there is good news there that indeed, yes, coffee, tea, caffeine consumption are associated with better kidney health and lower risk of kidney disease. In fact, coffee drinkers have up to 40% lower risk of developing kidney stones. Caffeine is a diuretic, so it increases urine flow. Coffee and tea also contain some antioxidants. They also have some anti-inflammatory properties. So a moderate consumption of coffee, tea, coffee, etc., for example, 3-4 cups a day is quite safe, and it may even be beneficial in people with kidney disease. So that's good news. There is no difference between black coffee or if others add milk to the coffee, but at least there should be coffee.
So for the viewers, be happy. You are allowed to drink tea or coffee as per our nephrologist faculty. So good news for all of us. Thank you. So which kidney is more used in renal transplant? Because I have read that you were also HOD of transplant unit of PGI. So let us hear from you yourself.
Yeah. PGI does a lot of kidney transplants,
Yes.
close to 50 kidney transplants every year.
And
But to the specific point, left kidney is usually preferred for living donor kidney transplants. So in the deceased donor or cadaver donor, we obviously use both kidneys because both the kidneys are then taken out. But in living donors, we take out obviously only one kidney. We can't take out both. In that case, the left kidney is preferred. Why? Not because of any intrinsic property of the kidney, but because its renal vein is longer. So it is easier to take out, and there is a longer segment available for anastomosis. So that really is the answer to your question.
So after renal transplant, does the longevity of the patient or the person increases, and it increases for how many more years? Suppose one has a transplant, so how much 5-year prediction from your side you
So
will live?
the survival of transplant patients has become very good now because the medicines that we use to prevent rejection, medicines to prevent development of infection or treat infection in transplant patients, they're very good. And so with proper or appropriate drug therapy, the survival in transplant is now quite high. If someone gets a deceased donor kidney transplant, they can expect on an average at least 30 years of extra life. And if they get a living donor transplant, and on an average, if everything remains well, then the life can go up by almost 40 years. However, having said this, all patients who undergo transplantation do remain at risk of developing either organ rejection or other complications. So it's important that they stay under constant medical supervision, they undergo all the tests that are recommended, and ensure that they maintain a healthy lifestyle to get the maximum benefit out of the transplanted kidney that they get.
And the person who donates kidney, what about him? Is
Right.
can he live with one kidney?
Yeah. So again, very important question. In transplantation, the most selfless person actually is the donor, because the donor is donating a kidney without any direct benefit to himself or herself. The recipient obviously gets the gift of life, and the hospital and the doctors, they make money, obviously, so they are also gaining. But the donor is not gaining anything. They are only gaining some degree of happiness because they help someone else. So it is our responsibility as the medical community to make sure that we investigate the donor thoroughly before transplant to ensure that they will not experience any adverse outcome as a result of their transplant. So the donor population, actually, those who ultimately go on to donate, is some of the healthiest people in the country because they have been thoroughly investigated. And after donation, it is not expected that there will be any adverse effect on their life as a result of donation. So they're expected to live a healthy life as they would have if they did not have to donate. It's also worth mentioning that there are many individuals who are even born with one kidney and they live a healthy, normal life. Many of them don't even get to know that they have only one kidney. The reason is that the remaining kidney, as I said right in the beginning, our kidneys have good ability to adapt. So the remaining kidney in the donor, it sort of starts to compensate for the function of the lost kidney. And it doesn't lead to any harm in the donor.
So nicely explained, huh? Very nice. So is there what are the immunological causes of nephropathy? Nowadays, we are getting lots of cases suffering from immunological disease of the kidney. So
there are a variety of immunological causes of kidney disease. And so most of it is because the body's immune system turns on one's own organs. So they're called autoimmune causes. And so these conditions are called IgA nephropathy, membranous nephropathy, lupus nephritis, as we all know. And then there are other causes like ANCA-associated vasculitis and nephritis. And sometimes even infections can lead to abnormalities in the immune system. So infection-related glomerulonephritis, which can be as a result of streptococcal infection, hepatitis B, hepatitis C, etc. So we always look for these infections whenever we encounter someone with kidney disease.
And those are treatable, the immunological diseases?
Many of them are treatable. Many of them are treatable. We are trying to find better treatments. And the response also varies according to the individual. Some individuals respond very well, others don't respond so well. Some may not present early because they don't feel any symptoms, and so unfortunately they may not respond as well as those who present early. So it is a bit variable.
Because these patients even can't take transplant also, because immunological disease.
They can, if kidneys fail, they can get a transplant. But there is a bit of risk of recurrence of immunological disease, so we have to keep monitoring them.
Is there any gender difference in management of renal disease?
So there is no gender difference in the biological management of kidney disease. But unfortunately, women receive less optimal care than men, and this is true all over the world. Uh, there are data that show that women are almost 50% less likely to be diagnosed with CKD despite having similar degree of kidney function. Their kidney function is monitored less frequently. They see nephrologists less frequently, and they often don't receive the best kidney protective agents. And they are not even referred to nephrologists even when they require dialysis or transplantation. However, what is also interesting is that women often
So
progress.
now coming to, so during antepartum period, if a woman is diagnosed with albuminuria due to gestational hypertension, what is the risk of chronic renal disease later in her life? Is there any risk?
Yeah, there is a significantly increased risk of development of chronic kidney disease later in life. Almost 40% risk of future albuminuria also, even if they don't have any traditional risk factors. If a woman has had preeclampsia specifically, then their risk of developing more advanced kidney disease later in life increases by almost 5-folds. In the case of gestational hypertension, it is almost 3.5-folds. And this risk will remain there for up to 30 years after pregnancy also. So essentially why I'm saying all this is that all women who have had hypertensive pregnancy, whether it is because of preeclampsia or gestational hypertension, they should receive long-term monitoring for kidney function, blood pressure, and proteinuria.
Yes, they have to be very, very watchful on their kidney health.
Yes, that's right. That's right.
So what are the features suggestive of renal disease in pregnancy? We have discussed these things, no? Same as.
Yeah, it is more or less the same. So some are pre-existing indicators, but otherwise during pregnancy, I'm sure you all do this. If the proteinuria persists or if it worsens, if the kidney function declines, if preeclampsia appears early onset preeclampsia is an indicator of kidney disease. And this can, if it is not detected in time, then this can lead to complications. There can be fetal growth restriction, there can be oligohydramnias.
Coming to that, I will ask the question later on.
Sure.
So what are the features suggestive of renal disease in pregnancy? It's the same. So what are the additional advice from your perspective to pregnant women apart from the routine antenatal care?
Yeah.
So I've seen a patient suffering from albuminuria. She's also hypertensive. And now we refer sometimes to the nephrologist. And what is your take on that? What
that's
especially
right.
your advice?
So women who have kidney disease, they should plan their pregnancy, obviously, and they should seek even a preconception advice.
Because now we don't have this concept in our community, preconceptional care. So the moment they land in pregnancy, they come to us for ANC checkup. And then we can come to diagnose that they're suffering from blood pressure, and then their urine is also showing proteins. And then we refer those cases to the physicians or nephrologists. So
why I said this is, so the first part of my answer was relevant to women who already know they have kidney disease, because sometimes they are on drugs that need to be stopped before pregnancy, like ACE inhibitors, angiotensin receptor blockers, or other drugs that may have teratogenic potential. So we do need to stop them. However, the situation that you are describing, where kidney disease is discovered for the first time, they should obviously be referred immediately to a nephrologist so that their kidney function and proteinuria monitoring and rest of the evaluation can be done to find out what is the cause of kidney disease those women. Sometimes we detect kidney disease which has a very high risk of progression, then we may in consultation with the obstetrician, with the gynecologist, also need to advise that pregnant woman to consider terminating the pregnancy if that, depending on the nature of the disease. Because if the kidney disease is highly aggressive, then we need to do this. But then if that is not the case, pregnancy obviously can be allowed to continue. But we should consider, for example, low dose aspirin for preventing preeclampsia. We want to make sure that they receive other supplements like vitamin Ds, etc. And of course, as the pregnancy progresses further, then you will need to determine, and that is something you know better than me, the anesthesia referral, etc., and whether or not a woman will need to undergo preterm delivery, depending again on the nature of how the disease is progressing.
Yes. So, what are the effects of pregnancy on renal disease?
So pregnancy can accelerate pre-existing chronic kidney disease. Unfortunately, the first thing to say here is that most women who have advanced kidney disease, they will not likely get pregnant, even naturally. But if they get pregnant, there is always the risk of further accelerated progression of kidney disease. And in women with more advanced types of CKD, almost half of them will lose more than 25% of pre-pregnancy EGFR, or will require dialysis within 1 year of delivery. So pregnancy on an average can bring forward the need for dialysis by about 2 to 4 years. So that's something which is really important. And we should identify the risk factors of progression. They include pre-pregnancy proteinuria, if the blood pressure is poorly controlled, and if the woman develops preeclampsia, then obviously the risk of progression of kidney disease increases further.
So, this question also I wanted to ask you. Patient has delivered, she has delivered a healthy baby, and now she needs postpartum care. And because we have diagnosed renal disease during her pregnancy, so we outweigh refer to the physician for the further advice, so that they have an optimum renal health post pregnancy. So, what will be your take?
So that's absolutely right, that the woman should be referred to a physician or to a nephrologist, and she should undergo kidney function test, especially at 6 weeks after delivery, or more frequently if there is a requirement or any concern. Postpartum eclampsia is also something we should always look for, and although it's not that common. The next thing to say is that, as I said a little while ago, in women with pre-existing kidney disease, we stop certain nephroprotective agents because of their teratogenic risk. It's really important that we restart those medicines after delivery, so in the postpartum period. So ACE inhibitors should be restarted, angiotensin receptor blockers should be restarted. And over the long term, as I said, there is a risk of increased rate of progression of kidney disease. So we should assess the trajectory of kidney function loss after delivery from the one before delivery, because those who do show more accelerated EGFR loss or kidney function loss, they will require even more close follow-up, and some may require dialysis transplantation. And of course, the general principles that tight blood pressure control, again, conception counseling, they should be, even if they did not know they have kidney disease earlier, now they know they have kidney disease. So if they want to plan pregnancy again, they need to be counseled appropriately, and the rest of the management for any kidney disease should be continued.
Very nice. So now we have covered almost many of the questions, but few important questions I wanted to ask you. So I'll ask: if a patient has undergone renal transplant and she has come to you to seek medical advice to conceive, what would be your advice as a nephrologist? Should she go for pregnancy, or she should not? She has just 1 year only of transplant. She's come.
A good function obtained after kidney transplant is the best time to have to plan a pregnancy and to give birth. But we should advise the woman to wait at least 12 to 18 months after transplantation to make sure that the kidney function is stable, the drug doses have been stabilized. We also generally check whether the kidney function is stable. There has not been any recent rejection. The EGFR is more than 40 to 50 mils per minute. Proteinuria is controlled, blood pressure is controlled, and she has completed all other types of prophylaxis, and the immunosuppression drug dose is stable. So if that requirements are met, I think she can go ahead and plan her pregnancy.
And what about the immunosuppressive drugs? Do you reduce the dose or you omit it?
So again, important question. So certain drugs in the immunosuppressive category are also teratogenic. So we stop those teratogenic drugs and replace them with drugs that are not teratogenic. So the drugs that we stop are mycophenolate if she's on it, or sirolimus. And pregnancy compatible immunosuppression usually is tacrolimus, azathioprine, and low dose prednisolone.
Very important answer, because I really wanted to know this. Because nowadays we are also getting patients who had undergone transplant and coming to us for the treatment, and we try to refer those patients to higher institutions that we won't be able to take up your pregnancy. So this is, I mean, a very, very satisfying answer from you.
Yeah.
So is there any effect of renal transplant on that pregnancy if she conceives?
So, as I said, renal transplant is the best option for a
Yeah.
woman who wants to conceive. So, because the outcomes are much better than that of pregnancy on dialysis patients. Almost 80% of women who have undergone transplantation will give birth to a live baby. But they are at increased risk of developing preeclampsia. Almost 20% will develop preeclampsia. There will be some degree of increase in hypertension. Some women remain at risk of preterm delivery as well. And of course, the cesarean section rates are usually higher than in other healthy population. So that really, there is of course, the risk of low birth weight baby and all of that. So these are the likely effects of transplantation on pregnancy. But if managed well, the outcome is generally a satisfactory one.
So you allow one pregnancy, or she can take another pregnancy also?
No, there can be multiple. If the kidney function remains stable, there is no proteinuria, blood pressure is well controlled, why not? But please be aware, for each, the risk of complications like preeclampsia, etc., is real.
Yes, and they have to be under care of a good nephrologist as well as a very experienced gynecologist, so that
Correct. It is a
get that.
multidisciplinary, it is multidisciplinary care that we suggest, which includes nephrologists, transplant nephrologists who has experience in transplant, but also a good obstetrician. So that's it.
And the delivery should be taken into tertiary care hospital, I think, because
Doesn't have to be tertiary care, but it should be obviously in a well-equipped hospital that can manage complications of delivery.
So with this, we come to the end of the questions, and your message to all for the entire population of our country and also across borders, what will be your suggestion to one-line answer to have a good kidney health?
Yeah. If you allow me, I'll make 2 points.
Yes.
The first point is
5 minutes more. So
no, I won't take 5 minutes. I'll take 2 minutes, I think.
okay.
So the first point is that, as you said yourself, that kidney disease in the community is common, and it is becoming perhaps even more common.
Those hospitals who had one dialysis bed, now it is increased to 20 hospitals. I'm talking about our own hospital. They have 2 beds of dialysis. Now it is 20 beds of dialysis, and the patients are in the queue. So you can understand what is happening to our country. So I'm really very, very much concerned about this.
Yeah. But I think the hopeful news there is that even though kidney disease is common and kidney disease is harmful, it can actually be prevented. If detected in time and if managed properly, we can prevent the development of complications of kidney disease, which include cardiovascular disease, infections, requirement of dialysis, and other similar complications, anemia, bone disease, etc. So people should take care of their kidneys by ensuring that they adopt all the ways that they can stay healthy. That's number one. And secondly, those who have increased risk of development of kidney disease, they should get their kidney function tested on a regular basis. That's number one. And my second message is relevant to women's health. As I said, it's very unfortunate that women in our country receive less optimal care than men, not only for kidney disease, but for many other conditions. And it is our responsibility as a society, as medical professionals, to make sure that we extend all the newer advances in medicine to all our populations, and we don't leave behind women. Until recently, it was thought that women's health is restricted to providing just care during pregnancy and postpartum state. But we now know that women also are at risk of developing non-communicable diseases, including kidney disease, cardiovascular disease. So their non-communicable disease risks should not be ignored or underplayed, and they should have the ability to undergo all kinds of appropriate tests and receive therapies as other members of the society do.
So the awareness is very important. Awareness is very important in the entire community.
Yeah. And I'd like to again end by thanking you and thanking FOGSI for providing me with this platform to talk to all of you and to talk to all of your members and the FOGSI community.
Thank you very much for being with us, and thank you. Our FOGSI is enriched by your all messages, and those are very important. I hope our viewers are satisfied, and look forward to have you more often on our platform. Thank you very much.